So thanks. It's an honor and a pleasure to be asked to speak here today. And I'm just going to try and provide a very brief synopsis of what is an enormous disease in the next 8 to 10 minutes, including some of the clinical presentation, the diagnosis, and the treatment of this disease. And as many of you may know, celiac disease is an immune-mediated disease that primarily involves a small bowel. And recent evidence has suggested that this disease may afflict as much as 1% of the North American population, of whom up to 80% may be underdiagnosed or undiagnosed. And the hallmark clinical pathologic presentation of this disease is loss of absorptive small bowel surface area, which leads to multiple potential deficiencies in macronutrients and micronutrients. And this is a disease that occurs in genetically susceptible individuals when challenged with a group of proteins called glutens, which are typically in wheats, barley, and rye, and to some extent in oats, but not present so much in rice or corn or maize, for example. And because theoretically the early part of the small bowel is exposed more to higher concentrations of gluten in such individuals, this tends to be a disease that affects the small bowel more so proximally than it does distally. And typically the duodenum, which is the first part of the small bowel, is the most severely affected part, but then variable extents of jejunum and ileum, which are the further on parts of the small bowel, may also become variably affected. And celiac disease can lead to a number of signs and symptoms. This is just a short list of common signs and symptoms, including fatigue, generalized abdominal bloating, increased gas production, diarrhea, and particular types of diarrhea where fat malabsorption leads to bulky malodorous stool known as steatorrhea, crampy abdominal pain, weight loss, iron deficiency anemia relating to micronutrient deficiency, pruritus, which is really related to a associated condition known as dermatitis herpetiformis that often is associated with disease, as well as abnormal menses. But like I say, there are many additional symptoms which may present in this disease. But that being said, in fact, we're learning more and more that the vast majority of people who have pathological celiac disease, in fact, may not have any symptoms at all. And there is a celiac iceberg that's been well described. And in fact, what has been typically thought of as being symptomatic celiac disease is really the very tip of that iceberg. And the vast majority of individuals may have small bowel findings consistent with celiac disease, but may not have any symptoms or micro or macronutrient deficiencies. And so that's an important point to keep in mind. And to date, we haven't entirely teased out what the natural history or long-term implications are of patients who don't have symptomatic celiac disease, but do have pathologic findings consistent with that disease. In addition to symptoms, celiac disease, either by virtue of chronic bowel inflammation or its effects on macro and micronutrient deficiencies, can lead to a number of complications, including, to name a few, osteoporosis related to calcium and vitamin D malabsorption, lactose intolerance due to bowel inflammation, generalized malnutrition leading to weight loss, a rare manifestation, perhaps chronic hepatitis, various neurological manifestations, also fairly rare, but well described, including seizures, loss of coordination, both of limb and overall body, weird loss of sensation or painful sensations in the extremities, infertility in females, growth retardation in children, and certain fairly serious complications which have potential mortality outcomes, including small bowel cancer, as well as a rare variant of celiac disease known as ulcerative jejunoileitis, which is really severe ulcerating inflammation involving most of the small bowel. Furthermore, there are a number of associated conditions that the physician and the patient have to be aware of in somebody who has been diagnosed with celiac disease. Perhaps most commonly dermatitis herpetiformis, which is a severely itchy condition related to deposition of certain antibodies in the underlyings of the skin, but various autoimmune diseases have been well described in association with celiac disease, including type 1 diabetes mellitus, rheumatoid arthritis, lupus, Sjogren's syndrome, and thyroid diseases, as well as several other conditions, including Down syndrome. So how is celiac disease diagnosed? Well, really there's two phases to diagnosis. One is through a screening test, and a screening test is typically a test that detects many people who potentially have a disease without missing too many people, which can then be followed up with a diagnostic test. And the typical screening tests that are applied to make an initial presumptive diagnosis of celiac disease are blood tests, specifically for antigens that attack components or proteins within the small bowel that seem to be altered, you can say, in the presence of gluten in a genetically susceptible individual. And the two common antibodies that are tested in the blood are tissue transglutaminase as well as anti-endomysium antibody. And both of these tests are very good, very accurate tests with high sensitivity and high specificity, but they do have the potential to be wrong as well. And furthermore, given the difficulty in establishing a lifelong gluten-free diet, typically these tests are followed with a diagnostic test as well. Importantly, from a practical standpoint, these tests, at least in Ontario, are not covered. And so if they're ordered in an outpatient facility, in fact, the expense is borne by the patient. These tests cost about $120. If you want to circumvent that, have it ordered in a hospital facility, and you can get your lab test for free. These are some characteristic findings in quite severe celiac disease. So and in fact, this gets to the point that really the diagnosis of this disease is firmly established using gastroscopy, which is an endoscopic examination of the proximal small bowel with biopsies, so that the pathologist can look under the microscope and tell us about characteristic findings. Endoscopically, on the left, you can see here very severe sort of fissuring and a mosaic type pattern, as well as really loss of surface area of the small bowel in very advanced celiac disease. And histologically, on the left-hand side, the normal histology with nice villi that promote increased mucosal surface area for absorption, these are completely destroyed by inflammation in advanced celiac disease, as you can see on the right-hand side. So celiac disease treatment is really, for the most part, fairly simple, although it's hard to do. The mainstay of treatment is strict, lifelong, gluten-free diet. And that sounds simple enough, but gluten is in many, many things. And although it's simply said that the Brau mnemonic for barley, rye, oats, and wheat, that's fine, avoiding foods that have those in them, but in fact wheat is added as a filler for many foods, and in fact it's very difficult to provide a comprehensive list of foods to avoid, but really what's important is to pay attention to the ingredients on every package, looking for proteins from any of these types of products. But in certain refractory cases, it may be important to institute certain therapies, specifically immunosuppressive therapies such as steroids, azathioprine, and potentially others which are still in the research realm. And furthermore, while treatment is being established, it may be important in people who have had advanced disease for a prolonged period of time to establish nutritional support with vitamin and mineral supplementation and various alternate forms of diet to increase weight and overall nutrition. So essentially, consulting a dietitian in cases of refractory celiac disease, it's important really to establish that gluten has been avoided entirely, and I can't stress that enough. So gluten contaminates many sources of food, so that would be the first step to make sure that gluten is being avoided. But then evaluating for other potential causes of symptoms, which can be done in consultation with your physician, and in true cases of refractory disease that are established to be related to celiac, aggressive immunosuppressive therapy, as already stated. So I'll stop there. This was just a mnemonic put forth by the NIH in a consensus statement in 2004, highlighting some of the important principles of celiac disease management. Thanks.